All right, welcome back to the 18th Indoanesthesia 2021. This is our final week. This is the last Saturday and Sunday of our virtual symposium. As for this afternoon, we will discuss about ophthalmic anesthesia. And we also have two prominent speakers in the field of ophthalmic anesthesia. They are masters or professors. Their specialties in the ophthalmic anesthesia. And I think they will share a good insight about the first speaker is Professor Chandra Kumar from the Singapore. He will talk about sedation and analgesia for cataract surgery. And our second speaker is Dr. Alfred Chua from Australia. And he will share his insight about the anesthesia for ophthalmic procedures in patients with thyroid eye disease. And for these sessions, it will be led by Dr. Aida Tantri as the chairperson. Okay, I think everyone, without further ado, I will give the spotlight to Dr. Aida.
Thank you, Krisha, for a very nice introduction. And today I will like to moderate a session with Prof. Chandra Kumar and Dr. Alfred Chua. This session is talking about ophthalmic anesthesia, and we all know that ophthalmic anesthesia nowadays is becoming more, may I say, popular, because we now have an increasing patient for ophthalmic procedures. In spite of the delicate procedure, ophthalmic anesthesia is very known of the very specific population, like a geriatric patient or a very young infant patient. We will start with our first distinguished speaker. Our first speaker is Prof. Chandra Kumar. He comes from Singapore. I think I don't have to explain about him more, because he is very known as one of the pioneer in ophthalmic anesthesia. He is a senior consultant in anesthesia in Tech Hospital, Singapore. And Prof. Chandra Kumar will talk about sedation in cataract surgery. Okay, Prof. Chandra Kumar, now time is yours.
Thank you. Thank you. Can you see my slides?
Yes, Prof, clearly.
So I go ahead?
Yes, please.
Okay, thank you very much, Dr. Aida, for kind introduction. I'm very, very pleased indeed, and it's wonderful and a pleasure to be invited to the 18th Indoanesthesia. In fact, this is my 14th participation. 13 of them have been live and present in Jakarta, but obviously this time we cannot. Before I start my presentation, I would like to thank Krisa for being an excellent master of ceremony for last 3-4 weeks. She has been there all the time. Finally, I would like to thank my dear friend and brother Susilo and Eddie and Bambang, the scientific committee, for inviting me to give a talk, a topic which is very, very close to my heart. That is the sedation and analgesia for cataract surgery. I have contributed on the subject and will go along with that. So before I believe there are several ophthalmologists and nurses other than anesthetists have joined this meeting from different parts of the world. So I will have to keep the talk in slightly relevant for all of them. So before any further ado, I would like to go ahead with my talk. So thank you very much again, and terima kasih. I cannot change my slide, can I? Could you change, please?
I think it's coming.
Yeah. Okay. So I need to declare first that I do not have any financial interest. The presentation is, of course, limited to sedation for cataract, and it excludes any other ophthalmic procedure. In fact, if you wanted to, you can apply the same principle. And also, I'm excluding sedation for procedural sedation. That's an entirely different talk altogether. There would be no mention of pharmacokinetic and pharmacodynamics in this talk, and the contents are suitable for sedation during cataract surgery. Now, who are the sedation provider? Basically, the anesthetists provide sedation in the most part of the world, but it's not unusual to have non-anesthetists providing sedation, such as nurses, respiratory therapy, and some other names like, I don't know what the names are, such as in USA, Canada, and Scandinavian countries, non-anesthetists also provide sedation. Sometimes ophthalmologists provide sedation as well, but they are usually a non-intravenous drug in some units. These are some of the contributions I have made over the years, and I will be referring to them as you go along. But this particular one, I would like to spend quite a lot of time on this document, which is dedicated local anesthesia guidelines, which was published in 2012. And I happen to be one of the co-author of this paper. And there are many other, 10 other people are co-authors of this paper. So I'll talk quite a lot. And very recently, we have published on sedation and analgesia during cataract surgery. This was in December 2019. So most of my content of my talk would be based on this paper. So, as Dr. Ada already mentioned this, the cataract surgery is usually performed under local anesthesia and often in elderly and comorbid patients. So that's the challenge. That's why local anesthesia is so common. Of course, like any other surgery, anesthesia and cataract surgery is also associated with fear, anxiety, discomfort, and pain. And of course, because of this problem, the ophthalmologist or often patient, they request, or sometimes actually they demand sedation or analgesia for cataract surgery. So in the next 25 minutes, I'm going to cover the topic under the following headings. First, we'll look at some of the terminology which are relevant for us. Then we'll look at the practices. Then why use sedation and analgesia? And if you do, which agent and how do you administer them? Are there any side effects? And what can we do to prevent those side effects? And then we'll talk about the practicalities. Let's look at some of the terminology. That's very important. So we talk about anxiety. So what is that an anxiety? Anxiety is excessive fear about a procedure during or in anticipation of the procedure. So basically, anything you do to the patient, they are anxious. And there are three terms which are more important. One would be fear of needle, which is called trypanophobia, or there's a fear of surgery or procedure, that's called tomophobia, or the fear of a doctor. Some patients are frightened, and they call it a white coat syndrome. That's the iatrophobia. But you don't have to remember all that. But nevertheless, what I'm trying to say, during surgery, anesthesia, there is some anxiety. How about the pain? The pain does have a definition, but I'm not going to go into the scientific part of it. What it is an unpleasant physical sensation in the body caused by illness or injury. And in this term, injury would be surgery. So the pain is inevitable with surgery, and the incidence is much higher in the patient, particularly those who are anxious. Let's look at the sedation. What is it, the minimum sedation? This has been very well defined by American Society of Anesthesiology, and I'll read it for you. The minimum sedation is a drug-induced state during which patient responds normally to verbal commands, although cognitive function and coordination may be impaired, sometimes yes, but the ventilatory and cardiovascular functions are unaffected. So if you look at the bottom slide, normal to response to verbal stimulation, airway is unaffected, spontaneous ventilation is unaffected, cardiovascular functions are unaffected. But what is a moderate sedation? It is again a drug-induced depression of the consciousness during which patient responds purposefully to verbal command, i.e. you have to shout, you have to do physical stimulation, either alone or accompanied by tactile stimulation. No interventions are required to maintain a patent airway, a spontaneous ventilation is adequate, cardiovascular function is usually maintained. So if you look at the bottom of the slide, yes, the person responds to you. No intervention required, spontaneous ventilation is adequate, and the cardiovascular function may be maintained. But deep sedation is a different problem. Deep sedation is the normal response after repeated or painful stimuli are basically lost. So you have to make an effort really to talk to the patient. Intervention may be required for the airway, and a spontaneous ventilation may be inadequate, and cardiovascular function is supposed to be maintained, but depending on what you have used, it can be compromised. So that's a deep sedation. So what basically the deep sedation is coming towards general anesthesia, although it's not anesthesia. Let's look at one more definition. That is the monitored anesthesia care. And actually, this term is very lightly used. And I don't think many people understand what it means. I haven't put the whole word in there, but there are 5 bullet points. They say the American Society of Anesthesiology is anesthesia clinician. And what they mean is not consultant anesthetist or anesthetist. It could be anybody who provides anesthesia. It could be non-anesthetist. Monitors and supports vital functions, diagnoses and treat clinical problems, administers sedative or analgesic, but should the need arise, able to convert the procedure into GA. And that means it's a difference. That means a person who is trained to perform GA can only monitor MAC. So what are the aims of sedation during cataract surgery then? Then, of course, some people are frightened, so we would like some angiolysis. Some people say, I don't want to know anything about it. But, so you might have to consider about amnesia, reduce perioperative discomfort of whatever kind, minimum side effects, quick recovery, and the sedation we are aiming for, it would be minimum or moderate sedation. No way we should hope to go to the deep sedation. So let's look at some of the practices of local anesthesia and sedation. This is the paper I talked about. This is a booklet which is freely available on the internet, and it was published in the Eye Journal. The type of anesthesia for cataract is usually is a topical anesthesia with or without intracameral, subconjunctival, or needle block, which is retrobulbar or peribulbar, more peribulbar recently, or subtenon block. But when you look at the preferences, we actually do not know. It varies within a country or within the hospital, within the unit, or even amongst the surgeons. So it's a very, very variable. Some people use retrobulbar, some use peribulbar. There are no consensus on the subject. But if we do use topical anesthesia, which is increasingly used worldwide, quite a lot actually, but although it's a painless to administer, but there are no life or sight-threatening complications. But it's not completely pain-free. And as it is not completely pain-free, some may decide to use sedation. When you look at the needle-based block, that's a retrobulbar or peribulbar. Peribulbar is the commonest nowadays worldwide, but retrobulbar is still being used. And the needle block are known to have sight and life-threatening complications, although rare. And of course, being an anesthesia technique, many people are anxious, the fear of pain during injection. And again, surgeons would request, or patient would request sedation. The cannula-based block, the practice is limited to certain countries, and we don't have exact data, but it's more common in UK, Australia, or New Zealand. It's a very rare sight and life-threatening complication, and usually you will find it's very good. So sedation is usually uncommon. The UK has offered guidelines, and this is one of the nice guidelines published in conjunction with the Royal College of Ophthalmologists, and have put that into red. They say, do not offer retrobulbar anesthesia for people having cataract surgery. But they do say also, offer subtenon or topical. They are very strongly encourage that. But they say if both subtenon and topical anesthesia are contraindicated or not suitable, then consider peribulbar. But no way you should offer retrobulbar. This guideline is issued from UK. There is no binding power on the other countries. Let's look at the sedation practice. Do we know about it? This is a world survey just published a month ago. Okay, but this world survey is subject to limitation and actually is not international and is subject to interpretation as well. So only 240 ophthalmologists were involved, 38 countries. So there are roughly about 200 countries in the world. 65% did not use sedation, but they did say that most surgeons consider sedation as desirable. So they want more and more people want the patient to be sedated. And they also recommended that the society and organization should develop guidelines. But obviously, those people who were respondent, they did not know about the existing guidelines. So let's look at some of the guidelines. So as far as the sedation is concerned, the sedation guidelines in UK, it says need basis and indications only. Australia and New Zealand college guidelines, I have looked at it, and they say no routine sedation for regional anesthesia, but practice varies in units. When you go to US, there is a paper by American Academy of Ophthalmology published in Ophthalmology Journal. They say sedation to optimize patient surgical experience of cooperation. So basically, in US, sedation is very common because they have recommended that. Then the next question, just look at why people use sedation. What are the reasons for it? So some of the things I've mentioned it, but look at some of the reasons why people use sedation. It's a tradition. It's an institutional practice. It's a cultural expectation. In some countries, you will find people cannot tolerate any pain. In some countries, they are different. Reduce anxiety and pain from surgery. We mentioned that before. Reduce pain of injection and intraoperative pain. That's important aspect, and we'll look at that one later. Some people use it for improved satisfaction of the patient or surgeon, or reduce the intraoperative visual experiences, cost and legal claims. Let's look at some of them. Let's look at the anxiety. Anxiety occurs at all stages of cataract surgery, not just cataract surgery, any surgery. So it happens during a whole lot of procedure, as you can look at it, during administration, draping, light, lid speculum, incision, capsulorhexis, hydrodissection, phaco, cortex removal, lens insertion, wound closure. So every stage of the operation, there is some anxiety. How about the pain? Pain occurs during anesthesia administration, and we'll look at it into more detail. And there are also pain intraoperatively. Intraoperatively, there are pain like such as microscope light, capsulorhexis can cause pain, viscoelastic filling can cause you pain, movement of the iris, lens insertion, and even the antibiotic injection can cause you pain. So if you look at the anesthesia administration, the needle block is most painful, which is highlighted in red here. Then comes the subtenon, is just here, which is at the bottom of the list. But of course, topical doesn't cause any pain. So sedation request is most common during needle-based block. When you look at the intraoperative pain, here you can see the subtenon comes at the bottom. So basically under the subtenon block, most patients are intraoperatively pain-free. But maximum pain occurs during topical. And some pain also occurs during retrobulbar and peribulbar block. No wonder sedation request is common during topical anesthesia as well as needle blocks. And this is another paper which has recently been published. And what I have highlighted is a very complicated table, but what I can show you in some of these patients, these papers, minimum pain with a subtenon, even if they are not sedated. So subtenon appears to be one of the good techniques, even in non-sedated patients, and there is not very much of pain intraoperative. And in fact, I can assure you that when you have done the technique, you will find the subtenon block is very good. How about satisfaction improvement? Okay, there are a lot of the satisfaction improvement. There are no objective data because satisfaction is very subjective. But let's look at the patient point of view. Patients are anxious, worry, fear. And of course, they will demand request. And if you don't give it, then patient is going to be unsatisfied. And of course, there are surgeons. There are two types of surgeons. One surgeon would prefer silent patient, doesn't want the patient to talk. And if the surgeon doesn't want the patient to talk, either they will demand sedation or keep shouting and the patient don't talk. And there are other surgeons who prefer to talk to the patient, particularly those who do topical anesthesia. They would like to talk to the patient, look up, look down, and I'm sure you have already seen that. I mentioned briefly about the intraoperative visual disturbance. It's very well known, very well known. And people do use sedation and seem to work very well because the patients are fearful. And there are two important reasons for using sedation. One, some people take the economic data and say, TA with sedation is a minimum cost in it, so it saves money. But there are other problems such as complaints and legal claims. This was one of the paper in where there were 96 claims and the 4 were related to excessive pain. So if there is a pain or whatever the technique the surgeon had decided to use, then of course those people would like to use sedation in these patients to prevent that. Then question comes, which agent and how do we administer it? Okay, before you look at the agent, selecting an agent, of course you would like to go and think about which drug to use. So of course the cataract surgery is very short duration, so you have to find a drug which is the duration of action is very short. Of course you will need to look at the pharmacokinetic and pharmacodynamic profile of the drug, and if you mix them together, then you have to think about the synergistic action. One of the important thing about the sedative is that it's the patient response vary. So you have to think about that. Then, of course, if you're using a drug, some anesthetist sedation provider may have a particular preference for a drug, and in which you will see that later because I do have my own preference. And of course, the cost is another factor. Probably propofol may be $10 or $8. If you select remifentanil, that may go into $30 or $40. There are a variety of agents and there are wide variation in doses used in the literature. So what are the groups of the drugs which we use for sedation and analgesia? Of course, the sedative comes number 1, which are benzodiazepines, midazolam, lorazepam, timazepam, or there are other drugs like clonazepam and whatnot. The induction agents, which used to be thiopentone, which is no more people use it, or very few people. Propofol and ketamine is another agent which is used. Analgesic, many people use fentanyl. It's very commonly used in Singapore, not by me, but there are other people. If you go to UK and European part, many people use alfentanil. Some people venture to do remifentanil as a bolus dose or infusion. Some people combine the two drugs, and by combining what you do, you reduce the side effect and reduce the dose. And there is a newer drug such as dexmedetomidine, which is Presidex or clonidine, and dexmedetomidine appears to have a lot of interest in the recent literature. So the common drugs, it's a very small table, but I'll summarize for you. The only thing I wanted to show you, if you look at the dose ranges, every drug has a range of dose. That means it's quite a variable. So what are those common drugs, sedative and analgesic? Propofol, benzodiazepines, ketamine, dexmedetomidine, analgesic. Let's look at the problem. Most of them have some adverse effect. Some of them bad, some of them good. And if you look at the level of evidence, there is not really a strong or good evidence anywhere. And how about the recommendation? Everywhere is weak or no recommendation. But there is one drug which has got a strong recommendation, and that's propofol. It may be because the anesthetists use quite a lot as an induction agent. Okay, so propofol appears to be the best among these lots. How are they administered? So I've put everything together, lumped together as other than intravenous, because there are ophthalmologists who use sedation, but they can't use or they don't use intravenous, so they go on to oral, sublingual, or intramuscular, rectal, intranasal, transmucosal, or transdermal kind of thing. But intravenous, of course, you need a trained person to administer intravenous drugs, and that has to be an anesthetist, or maybe in some countries like the CRN or registered nurses or a physician assistant, particularly in the UK. So intravenous administration is allegedly the commonest and preferred by most anesthetists. It's a practical, it's an immediate drug effect. You can see whether it's a bad or good. Well, you want a good sedation, undesired effect will happen as well. So that appears to be, you can sort out things if it is intravenous. There are some people use single sedative, some people use single analgesic, or some people even combine them. And as I mentioned, to reduce the dose and reduce the side effect of the drug. IV propofol again appears to be commonest. Why and how it is given? It can be given as a bolus, simple. I find it very simple, and I'll come back to that my preferred technique. Then if you use infusion, then of course it will make the cost higher. It would be costing cost. It would be training. It would need resources, such as if you give infusion, you may use it as a continuous, so you will need a syringe pump. If you are going to use target control infusion, again, you will need a particular pump. People use patient-controlled sedation, whether you want it for 20 minutes or 30 minutes, I'm not sure, but people have used it. Or there's a newer system called closed-loop system, where it depends on the hemodynamic data, and it can increase or decrease the amount of sedative going into the body. But of course, these will all be cost implications are there, resource implications, and you need training. So let's look at some of the adverse effects of this sedation. Why are we worried? There are a whole lot of problems, but we will concentrate particularly in those highlighted, such as airway obstruction. We all know about it. Respiratory depression can happen. Cardiovascular depression can happen if it is too much. Impaired protective reflexes and reduced. We know all about that, because the anesthetists, those who use sedation, they are aware of it. Let's look at in terms of the cataract. The biggest problem is unwanted movement. That would cause you an interruption of surgery, accidental damage. And let's look at the evidence, what it says. Unwanted movement occur more commonly in patients receiving IV sedation than those without sedation, of course. And many of you would have come across, if you use sedation, normally the patient who would not commit to you saying, I snore, but once you've given them the sedation, they start snoring. And if they snore, there would be unwanted head movement. And these are some of the legal reports. I'm not going to go into individual paper, but these are the medical legal report arising from the unwanted movement. And the ASA, that is American Society of Anesthesiology, have got the closed claims. Then American Academy of Ophthalmology had got the closed claims as well. So these are the papers suggesting to you that the complication can happen in the sedated patient because of the sudden movement. And this is one of the recent papers has come out from American Academy of Ophthalmologists, published in Ophthalmology Journal. They had 5 sedation-related claims, and I put them 3 into red. That is, the 2 are inadequate pain control, so they complained about it. And 1 was death allegedly related to excessive sedation. So they are warning. But you mentioned earlier, I mentioned to you earlier, that the American documents suggest that the sedation should be used with the regional anesthesia to improve the patient satisfaction and operation and so on. So how can we prevent, and what are the practicalities? Let's look at the preventive strategy. What can we do? I mean, this is just my thought. I put it on a slide, but you can make it even longer. There are many more things you can do to prevent problems. First, don't use sedation. That would be the best thing to use. Second, if you do have to use a technique which is relatively less pain, or pain-free, or less pain during injection, and also intraoperative less pain, and that comes the subtenon block. If you do have to use sedation, use a safer drug, do the proper dose titration, and of course, do the sedation assessment. But this is a big practical problem. How do you assess a patient within 10-15 minutes? That becomes very difficult, particularly if you are going to use Ramsay score or Iowa sedation score or any sedation score for that matter you like. It's very difficult to implement that clinically into the practice where 10-15 minute procedure. But what we do want to do is provide deep sedation at any cost, because that's where the problem is. And of course, when you are using sedation, then many people would like fasting. And of course, you need to monitor, you need to have the recovery facility, or need to give oxygen, resuscitation equipment, and so on. So let's talk about the fasting. Of course, we have looked at the starving patient before cataract surgery under regional anesthesia. Do we need or we don't need it? And we published this in Anesthesia, Analgesia. When we look at the why fasting, why people want patient to fast, most of the anesthetist or sedation provider will say, it is considered a good practice because I don't want any patient to have taken meal and give sedation. That's the big problem. Of course, people think that when patient is fasting, there is a lower aspiration risk. And particularly the kind of people we are dealing with, the older patients, they do have a high incidence of reflux. They do have a diabetes, most of them. And if they are diabetes, suffer from diabetes, you know the condition autonomic neuropathy, which can cause problem with the regurgitation. Should you need to convert the patient from RA or topical to GA, it's easy because the patient is fasting. And one of the good examples comes to my mind. You decide dementia is not that bad. Let's go ahead and do RA. And your assessment was wrong, and you start with that, and the patient starts to become uncomfortable or doesn't obey the command, and then you end up doing the sedation. The general anesthesia, of course, you like patient fasting for these. Of course, the regional anesthesia, very rare, although complication occurs, such as brainstem anesthesia, anaphylaxis can happen, cardiac arrest can happen, and if these things happen, you need to secure the airway. So if the patient is fasting, life is much easier. However, if you do fast the patient, they are suffer from hunger, thirst, anxiety, headache, and irritability, and actually many patients do take the food and don't tell you. They can also suffer from dehydration, hypovolemia, hypotension. And the biggest problem in clinical practice you will find is an unintentional omission of the essential medication, such as antithrombotic. Antithrombotics are given for a reason. But the moment you tell the patient, you need to fast, and they also assume, despite telling them, take the tablets, but they won't take. Antihypertensive, so the patient turns up on the ward with a high blood pressure. They have not taken the anti-diabetic. They will take the insulin, or they will take, so it can happen. So important drugs which are supposed to be taken, they don't take it. And of course, many anesthetists would say, if the patient is not fasting, I am not going to go ahead. So there are people like that. That's a strong view. But actually, there is a paper published in BJA, and this paper has come from France. As you can see from the top, Gourier and colleague, they had 15,000 or nearly 16,000 patients. 11,000 or slightly more were non-fasted, 70%. And out of that, 20%, that is 2,445 patients, they required sedation. So they did use. And they used propofol, boluses, 0.25 milligram per kilogram at every 2-minute interval. And they found there was no sedation-related adverse events. So they said low-dose propofol is safe, as you can see the heading of the paper. How about the monitoring? I mentioned to you about this paper in the college, the Joint Colleges Guideline. They say, of course, you need to monitor ECG, blood pressure, pulse oximeter, and end-tidal carbon dioxide have recently become common. But look at another paper which has come from Netherlands. They have done 4,347 patients, and this was published in Ophthalmology, which is one of the ophthalmic journal, #1 journal. And they had no anesthetist, they had limited workup, no monitoring, and they found that there wasn't any problem. They said the basic first aid and basic life support is still sufficient in the cases of adverse events. So anybody can do, look after the patient. You don't need an anesthetist to be there. But that's the next thing, whether you accept it or you don't accept it. Of course, the Joint Colleges Guidelines suggest that if you are giving sedation anywhere, then you should have a level 2 capacity bed somewhere. Appropriate nursing staff you need. And of course, you need arrangement for overnight stay should there be any problem in delayed recovery or experience any medical problem. That's an important. Nobody will dispute these kind of recommendations. But there are units where there are no facilities like that. And of course, in those units, you will consider not using sedation, in my view. Actually, is there any actual evidence for sedation usage? Does it help? This paper is slightly old, and one of the guy was Mark Feldman in there, but he is late Feldman. They looked at large number of patients and they found there was weak evidence for improved pain relief, anxiety, and patient satisfaction. There was insufficient evidence to recommend a particular drug or agent, and there was also insufficient evidence to recommend a particular technique or regimen. So basically, the evidence is not there. So if you use it because we are, anesthesia is demand-oriented, the surgeon demands it, patient demands it, then you do it. So what do I do in my practice? I'm coming to the end of my presentation. I use sedation on a need basis. While I was in England, I hardly used any. But when I came to Singapore, I found the sedation was very, very common here. So the unit where I work in Chua, we have abolished the sedation procedure and I only use it on a need basis. So what do I use? Because the procedure is so short, I usually get away by using bolus propofol, 10 milligram every 2 to 3 minutes, keep talking to the patient, and that's it. So I hardly use 20 milligram maximum. And these 20 milligram doesn't seem to do much harm to blood pressure or respiratory rate and so on. If the case is long, such as ECCE, then I use bolus, or if not, if the surgeon said it's going to be longer time, then I will use TCI, target control infusion, which is a very low dose, 0.2 to 0.3. It's not much, but you will find that even this kind of TCI dose may be sometimes too much. And I have used recently dexmedetomidine in respiratory compromised patients. I find it works very well. But the recommended dose is 1 milligram per kilogram per hour as an infusion for 10 minutes, but you haven't got much time for this. And actually, the literature tells you that you should not be using that high dose for elderly patients. So I find that 0.25 milligram is sufficient for me for long cases. So finally, what I can say to you in the summary slide, of course, you need to work on reducing the need for sedation. What can you do? Give them good information, reassure them, handhold, and do the subtenon block if you can. Use the sedation on the need basis, but remain below the moderate sedation. Don't go into the deep sedation area. Avoid deep sedation because we know that there are life, sight, and life-threatening complications known to occur with the serious consequences when the patient is, particularly when the patient is covered and draped, you can't see the full patient. You just need to rely on your monitors. And of course, whatever you're doing, please be monitor carefully these patients. Thank you very much for your kind attention. Thank you. Terima kasih.
Thank you so much, Prof. Chandra Kumar, for a very nice presentation. And I think it's very interesting and very useful for us who usually perform anesthesia or sedation for cataract surgery. There are several things that Prof. Chandra Kumar has emphasized to us. Firstly, sedation is needed I think is needed in many procedures in cataract surgery, but there is also disadvantages of sedation in cataract surgery. And Prof. Chandra Kumar gives suggestion to us to minimize sedation because it can bring risk and disadvantage. But Prof. Chandra Kumar also emphasized the factors to consider in selecting sedation agent and emphasized also how to monitor during sedation. I think this is a very nice and very interesting presentation from Prof. Chandra Kumar. Thank you, Prof. And for the second speaker is Dr. Alfred Chua. Dr. Alfred Chua is also very famous in ophthalmic anesthesia. He has many publications about ophthalmic anesthesia. He is a visiting anesthetist in Royal Prince Alfred Hospital, Sydney, Australia. Dr. Alfred Chua, time is yours, please.
Can you see my slides?
Yeah.
Okay, I'll start. First of all, I would like to thank Dr. Susilo and all the organizers for inviting me to give this presentation. I have been to Indonesia twice. I'm a newcomer, but each time I enjoyed the hospitality, the food, and the scenery. My talk is on anesthesia for ophthalmic procedure in patients with thyroid eye disease. The talks are essentially based on a review paper we published together with Professor Chandra Kumar and other colleagues, which was published last year. Other than that, I have no disclosure to make. I would like to talk about the background of thyroid eye disease, the surgical procedure associated with it, and the implication for anesthesia. Thyroid eye disease is an autoimmune inflammatory disorder. The pathophysiology cause is unknown. It's the most common cause of orbital disease in adults, prevalence around 19 per 100,000 population, female to male ratio 5:1. The clinical feature is because of the inflammation, expansion of the tissue, and subsequent fibrosis of the orbital fat, muscle, and the lacrimal glands. The clinical manifestation is related to the soft tissue expansion within a relatively inexpandable bony orbit. An accurate clinical evaluation is important. It allows you to identify the high-risk patient, implement and assess the response to medical and surgical treatment, and of course, look at the disease progression, etc. This is one of the patients we come across, and you can see from the picture, the typical features are the proptosis of the eyelids retracted up. These eyes uneven, got a restrictive squint, soft tissue swelling. She doesn't have, but in other patients, you can get optical nerve compression, corneal exposure, or glaucoma, which can be sight-threatening. There are a number of classification. Visa classification is one of them. It based on subjective and objective measures, and it allows you to assess the condition and the progress of the disease, and so that you can accurately assess them. The clinical presentation typically is biphasic. There's the initial active phase where there is inflammation, swelling, and it can have fluctuation of symptoms, and it may last somewhere between months or years. Following that, there's a quiescent phase with spontaneous resolution or regression of the active phase, and that will happen with atrophy, fibrosis, and sclerosis of the tissue which was involved earlier. The thyroid status at the time of presentation of thyroid eye disease are variable. 90% of patients are hyperthyroid. The remaining 10% is either euthyroid, Hashimoto thyroiditis, or hypothyroid, which is in a very small percentage. Majority of patients have self-limiting ocular disease. Unfortunately, 3 to 7% will have severe sight-threatening condition, as we have spoken earlier. Overall, about 20% of patients will require surgical interventions of some sort, and therefore requiring anesthesia. Medical management. Smoking is the most important modifiable factor. Both passive and active smoking are bad for the development of or deterioration of the thyroid eye disease and poor response to medical and surgical treatment. Conservative measures such as lubricants, sunglasses, sleeping with a slightly head-up position are helpful. Selenium, one of the antioxidants, are useful in retarding mild thyroid eye disease. Unfortunately, when it comes to moderate to severe conditions, you will need corticosteroid, immunosuppressant, orbital irradiation. No treatment can prevent or reverse the underlying tissue changes that already occurred. Surgery is not advisable until the patient's euthyroid and the thyroid eye disease are stable for 6 to 9 months. And the exception, of course, is urgent orbital decompression if there was explosive keratotomy or optic nerve compression. Surgical options are as listed, and it should be done according to this order, because each previous surgery will affect the subsequent appearance and outcome of the next surgery. So orbital decompression, either removing the fat or the bone, are done first, then strabismus, and the last one to be done should be the eyelid operation. Orbital decompression. The orbit actually behaves like a closed compartment. It has posterior, lateral, and medial bone wall, and minimum forward displacement. So as the tissue expands inside, the volume will expand and have a pressure volume loop behaving like a closed compartment. By removing the fat, plus or minus the bone, you will release the pressure. There's many surgical approaches to it. You can do it transcaruncle, transconjunctival, or transnasal endoscopically. Complications are typical diplopia. Small percentage, 0.5%, can have severe complications such as blindness. CSF lead meningitis are rare, but can happen. Most of these operations are elective, and you should consider antibiotic cover because they're on corticosteroids. In a series of 96 orbital decompression surgery, Stengard found that 30% of cases need atropine for ocular cardiac reflexes. Other drugs that may be used, such as acetazolamide or mannitol, to reduce the intraocular pressure, and you shouldn't consider to use a throat pack routinely. Why? When they did a systematic review, the literature was full of complications from the throat pack, but there was not a single evidence of benefit by a throat pack. Severe complications such as respiratory compromise or even death have been reported, and therefore the Free Society Association in UK no longer recommend routine insertion of throat pack. If you want to put it, you should place it in the surgical gown, and they recommend that the anesthetist is responsible to check the airway patency before extubation. In an urgent case for orbital decompression, typically they're hyperthyroid, and they are the patient most at risk. Beta blocker corticosteroids are often used to blunt the hyperthyroid symptoms. Close monitoring of the cardiovascular status, such as arterial or central line, should be considered, as well as the temperature. Hypothyroid patients are very uncommon. In strabismus, the most commonly affected muscle are inferior and medial rectus. And you can see in this particular patient, the right inferior rectus muscle are swollen up and enlarged, and that create a restrictive strabismus in this patient. There are a few different options to correct this strabismus. Botulinum toxin injection to the muscle is useful in small cases, small degree deviation. You can do it with EMG guided under topical anesthesia in cooperative patient. With anxious patients, you may need them intravenous sedation. We are uncomfortable with that technique when we use botulinum toxin injection. We actually give a patient GA, have an open exposure and direct injection into the muscle under direct vision. Then is the conventional surgery. And there's a newer technique, minimum invasive surgery, which they just change the middle 1/3 of the muscle. So it's mini tenotomy or mini pication. One of the more recent approaches is adjustable suture surgery, which involves 2 stages. Stage 1 is like the typical conventional surgery, but the suture are not tightened up and is left there for the patient to recover and you do it the second stage procedure. After the patient recovered from the general anesthetic, you check the line alignment, check whether they have double vision, check whether they have any more movement of strabismus when you look at near and close vision or distant vision, and it's done under topical anesthesia in the second stage. This patient, the same patient before, pre-op and after the orbital decompression and medical therapy, she come for adjustable surgery. After stage 1, the 2 sutures on both sides are attached with steroid strip, and we are waiting for the patient to look at the response before we tighten the knot. Sometimes we have to adjust the tension of the knot, release or tighten it more, depends on what happened. Eyelid retraction are most commonly done under local anesthetic with monitored anesthetic care with intravenous sedation. That's the treatment useful. The top one is the patient with initial presentation, and you can see the proptosis. The second picture shows the patient having orbital decompression and medical therapy, and you can see the eye come back to a more lateral position. When they come for surgical intervention, it is useful to have multidisciplinary approach, including the endocrinologist, surgeon, and anesthetist, and combined effort usually give you the best outcome. Investigation pre-op should be individualized. Thyroid function test, you should aim for the patient to be euthyroid. And there's an argument about you should do coagulation screening. In an orbit that is already tight and congested, any bleeding disorder causing hemorrhage or excessive bleeding leading to increased intraocular pressure will have significant detrimental effect to the vision. The two problems with the patient is either hyper or hypothyroidism. I just briefly go through both of them. Hyperthyroidism, a classical feature such as hyperactivity, weight loss, and tremor. And the particular concern to us is the cardiovascular status, such as atrial fibrillation, congestive heart failure, and ischemic heart disease. And they are usually on various medical treatments. When they have uncontrolled thyroid dysfunction, they're more likely to develop severe thyroid eye disease, and they have had increased risk of having thyroid storm. What happens when they are mild to moderate hyperthyroid? Does it matter? There's no figure on patient presenting for thyroid eye disease, but there is figures from patient presenting for thyroidectomy. Comparing euthyroid with mild to moderate hyperthyroid patient, intraoperative beta blocker use is much more increased with mild to moderate hyperthyroid biochemistry patient, although the mortality and length of stay, there was no difference. What about hypothyroidism? The classical cardiovascular status is bradycardia, hypertension, reducing myocardial contractility and cardiac output. The severe condition, max edema, coma, will lead to cardiovascular collapse and death. There is a debate about whether you should delay mild to subclinical hypothyroid patient when they present for surgery. There's one prospective study looking at cardiac bypass surgery, and they found that subclinical hypothyroid patients have more incidence of transient post-operative atrial fibrillation, although all the other outcome, length of stay, complication, etc., are identical. There is a retrospective study looking at euthyroid patient matched up with mild to moderate hypothyroid patient for all types of surgery. And in this particular study, they found that there's no differences. And the author therefore recommended that we shouldn't proceed with surgery, we shouldn't delay the surgery. We can proceed with it. What should we do? I personally think you should wait until they're euthyroid. the pathophysiology associated with hypothyroidism are easily reversible, most of them, by having thyroid supplement. And why not wait until they're euthyroid and when the patient's more normal before they present for surgery? They should stop smoking and they should stop the antithrombotic agent. And as we said, as I have spoken before, with the increased bleeding and hematoma, there is significant risk of the vision post-op as a complication. Other consideration, antibiotic prophylaxis, extracorticosteroid cover, and monitor their blood sugar level are important because they're on steroid therapy. The length of the surgery lasts somewhere between 1 to 3 hours, with the longer duration in bilateral orbital decompression surgery. So you should consider also thromboprophylaxis measures. Some surgeons will use vasoconstrictor. On an intact eye, vasoconstrictor will help to reduce the bleeding. But once the surgical started, applying vasoconstrictor to the raw surface in incidents such as strabismus surgery, case reports of severe cardiovascular side effects, including pulmonary edema, have been described even in children. So in the intact surface pre-op, using topical vasoconstrictor is okay. Once you open the wound, I don't think you should use it. Pacemaker and AICD device. In a survey among ophthalmic anesthetists, around 90% of them do not modify or stop any of those devices, and they do not report any incidents of side effect or problems. But given the close proximity of those devices to the surgical site, modify them may be preferable. If the surgeon needs to do a force suction test, which is grabbing the eye, moving sideways for different positions to check the restrictive nature of the squint surgery, using succinylmethonium would temporarily affect the force suction test result. The effect of succinylmethonium on the extraocular muscle lasts 4 times longer than its effect on skeletal muscle. So you may need to wait 10 to 15 minutes before they actually do the test. Other than that, there's no absolute contraindication of using succinylmethonium. Personally, if you can, using a non-depolarizing agent, you can get on with the surgery. Oculocardiac reflex, of course, is common when you manipulate the eye. Most of them are short and transient. With the surgeon releasing the stimulus, will return the heart rate back to normal. In small percentage, you may need to give them anticholinergic agents. There's also something called fatigue. If you hold on the stimulus continuously, the oculocardiac response actually reduces with time, and you may be able to ride out the wave if the oculocardiac reflex is not as severe. If you decide to give the patient a general anesthesia during a face mask ventilation, you've got to be careful. The eye's proptosed, the eyelid may not be able to close properly. They're more prone to abrasion injury with the cornea. You can either use a laryngeal mask airway or endotracheal tube to your own preference. Intubating the patient, if there's a presence of a goiter, it may interfere with your intubation. Maintenance of anesthetic, there's no difference between using volatile agents or TIFA. If you choose to use TIFA, you do need to increase the initial infusion rates of propofol, because during hyperthyroidism, the volume of distribution and clearance of propofol are markedly increased. So set your infusion rate higher, and then you can reduce it according to what your depth of anesthesia monitoring is guiding you. You should be vigilant about hypermetabolic state. Regional anesthesia, retrobulbar, peribulbar, and subtenon block are best avoided. Why? The orbit is already congested with higher pressure. The injectable volume, or unfortunately, if you cause any bleeding, the effect will be significant. This sensory to the ocular area are supplied by ophthalmic and maxillary branch of the trigeminal nerve. Blocking selective nerve either by itself or in combination are useful, such as supra or infraorbital nerve or supratrochlear nerve. What it does is it reduces the need to have local infiltration, and that may affect the tissue plane at the surgical site. If you want to inject local anesthetic infiltration technique, very important to limit the volume because the eye is already congested. Constantly using manual allotment to check whether the eye orbital pressure is high, whether the intraocular pressure is high. If there's any doubt, you should check their vision, either by asking them, can they see, check finger movement, check finger counting, and if necessary, the ophthalmologist may need to visualize the retinal artery. Adrenaline is useful to cause vasoconstriction and reduce the bleeding. Study looking at adrenaline concentration of 1 in 50, 1 in 100, and 1 in 200,000 have found the same vasoconstrictor effect on the tissue. So therefore, they recommended to use the lowest concentration of adrenaline. Hyaluronidase will improve the spread of the local anesthetic and reduce the pressure quicker, and some people use it with the local anesthetic solution. Topical anesthesia, is there a role for it? You can use it to do the strabismus surgery in motivated and cooperative patients. The disadvantage is if you use that, you can't really do the force suction test properly. The advantage is you can avoid general anesthetic, and it allows adjustable sutures strabismus surgery to be done in a single stage. Topical anesthesia is also used in a small series of orbital decompression surgery, but overall its use is quite limited. Monitor the anesthetic care. Professor Kumar have spoken about it before. I won't go into the details again. In summary, with the orbital decompression and strabismus surgery, most of them are given by general anesthesia. Eyelid surgery are mainly done under local anesthetic with some sedation. Regional blocks such as peribulbar block, retrobulbar block, subtenon block are best avoided in thyroid eye disease. Topical anesthesia use is very limited. And last but not the least, the eye is congested and swollen. The eyelid may not be able to close properly. Not only the operating eye, you should be careful. The contralateral eye, you should be also careful. You should check and protect it against corneal exposure. Thank you very much.
Thank you so much, Alfred, for a very nice lecture. It's about how we can perform anesthesia for thyroid patient who will undergo eye surgery. And there are a lot of things to consider. Like Alfred say, we must consider what type of surgery that the surgeon will perform, and then how the condition of the patient preoperatively, and what is the risk in performing anesthesia for patient with thyroid disease that will undergo an ophthalmic surgery. Thank you so much, Alfred. And I think now it's time for the discussion. We see that there are several questions now in the Q&A form. So I think the first question must be for Prof. Chandra Kumar.
Yes, it is. Thank you, Eda. Yeah.
Can I pick one question that I think that's a very interesting one, Prof? There are two questions, and I think that's almost the same. The one is how about patient selection? How about patient selection in performing sedation for cataract. Is there any consideration in picking, oh, this patient is suitable for sedation in cataract surgery, oh, this patient is better only with topical, or this patient is suitable for general anesthesia, or it is depend on the patient, it's him or herself that I like to choose this kind of
I
anesthesia?
think it's a very, very interesting question, which is in one sense, it's very difficult to answer. And Alfred may have his views as well. Patient selection of anesthesia and sedation is usually done by the surgeon, because anesthetists don't have much say. Right, because the patient has already been seen by the surgeon, had decided a preference of that surgeon, because it depends which country you work in, Ada. I know that in UK, in Australia, you work in a team most of the time. So you know what your surgeon wants, or what the surgeon knows what an anesthetist can do. So you do that. If I say, for example, if you give an example of Singapore, and I suspect the same system would apply to many parts of the world. In Singapore, the choice of anesthesia is determined by the surgeon. They know, they tell the patient that's how it's going to be done. That's number one. Number two, they change their mind on the day when the patient comes into the hospital, because they might not have seen the patient before. We're not talking about private sector, we are talking about the hospital sector. So the patient would be seen on the day by the surgeon, and he will say, this cataract looks very simple. I go ahead with sedation, with the topical. If the patient pathology is different, then they will say, I need to do a block. Now, when doing the block, I can assure you, in Singapore, most of the surgeons are still used to older retrobulbar block. Some of them, they do newer peribulbar block, but they say they are doing peribulbar block, but they might not be, because their technique is different. So in terms of anesthesia, and I suppose it also applies to Indonesia, to many other parts of the world, saying there are not very many anesthetists do the block. Singapore, I'm the only one anesthetist probably in the whole country who does the block, but I am very selective. I only work with people, those who have faith in me. So we work as a team. If the surgeon is happy with my service, I do the block. If they're not happy, they do the block, and they might tell me saying, if the patient is very anxious, would you mind giving sedation? So I do. And there are other related questions which I'll come back to. That is fasting and sedation. In my hospital and in England, all of England, basically patients are not fasted. You identify the patient before which patient needs sedation. But that doesn't mean that you can't go wrong. You can go wrong, that initially you thought the patient doesn't need sedation, but on the day the patient might need sedation. So do I give the sedation? I do. And I don't give midazolam, and I don't give fentanyl, I don't give remifentanil. I rely on 10 to 20 milligram of propofol, and that's what usually works. And that paper is supported by the study from France. I think Alfred might have some more comments to make. Alfred.
Alfred, do you have any comment about this, about patient selection for sedation in cataract surgery?
Similar to Prof. Kumar, in Australia, or at least in my practice, and I do a lot of them in the private, the surgeon pretty much dictate what they want. Now, you can have your input in there. For example, the surgeon's comfortable with topical, and they do most of this patient under topical technique. You have a patient who you can't even put the eye drop in. You go and tell them, I think the patient are better with a block. And they're quite happy to take my advice, for example. Other surgeon will dictate that I would only do subtenon. I don't want you to do needle block. And you have different surgeons will say, I don't mind what type of block you put in, just please don't have a complication. A bit surgically dictated.
Yeah.
Some ophthalmologists prefer to plan to some anesthesiologists prefer to have general anesthesia or maybe block for cataract that, that more hard, like hard cataract, a very complicated cataract case, because maybe the surgeon need more time to performing the surgery, and so they choose sedation for that kind of type kind of surgery. What do you think about it, Professor?
I don't think there is any problem, because you see, complicated surgery means what? It can go up to half an hour, 45 minutes, 1 hour. We do VR surgery for 2 hours, 2.5 hours. So it's not a problem. As long as you understand, we all understand what we're wanting to achieve. My important thing would be to avoid the deep sedation as much as you could. If you are hoping to go get deep sedation, better take up general anesthesia and just do it that way, rather than, because you see, the complications are the patients are sleeping like this. And if the sedation has gone more, suddenly this patient wakes up like that. Imagine the instruments are in the eye. The damage done, you cannot defend yourself. So anesthetists got to work in conjunction with the ophthalmologist, saying what is best for the patient. And as Alfred said, you're dictated by the choice of the surgeon. You hardly have much to say unless they are really worried. Then they ask you. There are some people, I can name one surgeon in Singapore who said, I don't want a local anesthetic for my patient. I want general anesthesia for everybody. And he's a very well-known private practitioner. But that's the way he is. So if you work with that kind of person, then you have no option of giving any other anesthesia. Just give general anesthesia. Whereas if you go to UK, you go to Australia, you go to New Zealand, they have got colleges. And we are dictated by, basically advised by the colleges saying what you should do. And I can't go against that, because if there is something written, and I tell you, I have written this guidance, which I mentioned to you earlier, that is by the joint colleges, which is the Royal College of Anaesthetists and Royal College of Ophthalmologists in London. We had representatives from both colleges, and we thought, what is the current practice? What should we do? Because we got to give an advice. Although it's a guide. Guide means we tell you that this is a better thing to do. We are not saying you must do it. So in terms of doing the technique procedure, we are largely determined by the surgeon choice, actually.
Yes, I agree with you. One more question from me. I'm so sorry.
One question, Ada, which I think many people would like to do, which is not a bad idea. And I mentioned in my presentation, non-intravenous sedation. And those kind of sedations are given by non-anesthetists. So, for example, there are many centers I'm aware of. The ophthalmologist will give a timazepam tablet or diazepam tablet, take home and come tomorrow with that. But obviously, the oral tablet, which has been given to the patient, is not in the same category as giving the intravenous, because intravenous, you're giving it, you're judging it. Sometimes it can go too much, sometimes remain less. So, this practice happens in many centers. And you can't do much because, those centers, they do not have a facility to recover these patients. So they rely more on oral tablets or oral whatever you are giving them. And it depends which country you are, what kind of setup you have. But the developed world would not do that, because this logistically is more of a problem. That somebody has to talk to the patient that this is the tablet you take at this particular time when it's coming in, and so on and so on. So logistically it's much more difficult. But it's easy for them to administer for ophthalmologists, because they are only doing ophthalmology. They are not doing anything else. So in a hospital setup, it's difficult to make it work. But in a clinic setup, where it's an ophthalmology theater, ophthalmology unit only, private practice kind of thing, it's workable. It's workable. And many people do that.
Thank you, Professor. One more question. I think I asked both of you about this topic about sedation. Sorry, Alfred, this topic is, I think it's interesting. What about a patient that become very anxious during during the surgery. So he come to the surgery, he planned to do, the surgeon planned to do topical anesthesia, and then intraoperatively, suddenly the patient become very anxious, and and the surgeon asks for sedation intraoperatively. How about your experience in it, Professor? Do you agree to give the propofol, or do you postpone the surgery until the patient ready to get?
But they're answering one of the question, actually, what we have done. Like, if I can take you two examples. I'm coming from a country where there is no sedation, no fasting. And if you need to do the sedation, you just use a small. That was England. I came to another country, Singapore, where everybody was fasted and everybody received sedation. And it takes time for people to understand what the problems of the sedation are and fasting the patient. So now I have gone from 100% fasting, 100% sedation in Singapore to no fasting, no sedation, but on indications. So patients are identified in the clinic beforehand that this patient is anxious. It would be flagged up. The patient might benefit from sedation. So this patient would be fasting. Not by me, but other colleagues are not happy. And I have to go along with my colleagues in the department because there are 25 of them. And I can't tell them that, you accept my practice. But I'm happy to give 10 milligram or 20 milligram propofol, no more. If something more is needed, I want the patient fasted or call it a day. Bring the patient another time. Because you cannot, clinically, it is not an urgent operation. If somebody is not suitable for local, you should know that in advance. And if you convert unnecessarily somebody to general anesthesia, I'm not sure medical legally we are covered. Alfred may have a different point of view. I don't know. What do you think, Alfred?
Yeah, Alfred, do you have any suggestion?
Well, all our patients are fasted. So if the patient hasn't got the surgery commenced and you want to convert it from one form of anesthesia to another form, that's easily done. Either topical, you don't think is suitable, you want to put a block, or you don't think even a block is suitable, you want to give a GA. In the anesthetic bay, you can discuss it and change it. Once you've gone into the theater and surgery has commenced, that's different, right? Any movement, there's a risk of infection, there's risk of coughing, moving on an opened eye. Well, you have to judge on case-to-case basis. We typically done with a block, although in a lesser extent, one particular surgeon I work with use topical. If I use a block, if they need sedation, for the block, I use propofol. Intra-operation for anxious patient, I may give somewhere between 1, maybe 1.5 milligram of midazolam. Converting to a GA, I have done it once or twice. Each time I'm extremely nervous about converting GA in an open eye operation halfway.
Thank you, Alfred. So question, I think the next question I like to ask Alfred during when we preparing patient for thyroid eye surgery, and the patient still in hyperthyroid condition. You can see still in tachycardia or still not in a very good condition, but it is an emergency surgery. Do you prefer? Do you ask the surgeon to do it locally, or you prefer to do it with GA or maybe in another technique?
Okay, I assume you're talking about orbital decompression surgery because we are not talking about cataract. For orbital decompression, the eye is obviously extremely congested. I think any local anesthetic volume on it will be even worse. So I'll give them all general anesthesia to start. I would not even consider local anesthetic as an option. Or at least to the surgeon that I work with, none of them are comfortable doing it that way. Endocrinologists are usually involved and typically will be beta blocker, corticosteroids. And I would minimally do them with an arterial line, for I don't usually put a central line in.
Yes, because sometimes not decompression surgery. They ask for only to close the lids, so it's not the exposure of eyes is not too wide, yeah, to protect the patient's eye. So
Okay. Okay. Tarsography, that type of surgery will be different. Okay. If you're doing tarsography surgery in a normal euthyroid patient, you can done them under local anesthetic. I don't know how much you can do with hyperthyroid. I certainly personally hasn't come across doing them like that. I would assume if the eye is not congested, you put a small volume in and constantly monitoring the pressure may be safer. I do not have any literature support one way or the other.
Ada, there are two questions I would like to answer. One is from Australia, Dr. Wilfred Lim, and the other one is from UK, Dr. Sashi Bora. Can I answer them?
Question
from Wilfred Lim from Australia.
Oh, okay. There is
what he's suggesting, or some of his colleagues are doing it. They use deep sedation for cataract with a high flow oxygen, which they have, whatever it is called, Thrive time. I'm not sure, Alfred, if you're listening to, Wilfred, if you're listening to me. I suspect that you get away, but why would you need deep sedation and noisy system, which many of the surgeons may not like it? I think the view would be that you as long as you, in anesthesia, it's a saying that something works with you, it has to be right, but it cannot be right for everybody. So if the technique works very well for you, I cannot say I'm recommending this. Because the point of the matter is the whole argument was that deep sedation should be avoided for cataract and so for vitrectomy as well. VR surgery, you don't want to go deep sedation, but equally, you've got to keep assessing that one. So, Wilfred, I'm afraid I haven't got the correct answer for you because I cannot suggest that you should use deep sedation and high flow oxygen. That's one. There is another one from Dr. Sashi Bora from UK. She's asking a very valid question, and it's a good point that she's saying, what are your views on post-operative disorientation caused by sedation, particularly in the elderly? That's a well-known common problem. So people, those who use midazolam or fentanyl or remifentanil, then you do have a risk of disorientation post-op. And that is why when I said this is my practice, I tend to use a small dosage of propofol, 10, 20 milligram maximum. I have not come across any disorientation problem, but I haven't done the study, so I can't tell you that. Second, if I do find that something I have to use, more recently, over the last 1 year, 1.5 years, I have been using increasingly dexmedetomidine wherever there is a problem. Because dexmedetomidine, there is some evidence, not in eye surgery, some evidence in other parts of anesthesia saying that tend to reduce the post-operative confusion and disorientation. So my inclination based on those publications would be that I would prefer to use dexmedetomidine, a small dose, but a small dose. I said higher doses will cause you hypotension and will cause you bradycardia. And those two together, hypo and bradycardia, going downward slowly like this is a sign of danger. So don't go for a high dose. I would suggest to you use a small dose. And I hope my friend Alfred would agree with that kind of sentiment. What do you say, Alfred?
I have similar view. I don't use deep sedation. I think deep sedation are potentially risky, but each to their own comfort level. I use dexmedetomidine very rarely. The problem, I think, is we use it on the infusion. It takes time to set up. 10, 15 minute surgery just seems to be a waste of time for cataract surgery.
Agree.
Yes, I agree that dexmedetomidine needs more preparation than give propofol maybe. But
I immediately didn't go into that because you say ideally it says 1 milligram per kilogram per hour. and you got to run it for 10 minutes. And we know from literature that it has caused problems. That kind of a dose in higher pressure. And as Dr. Alfred saying, yes, it is logistically, it's not good enough, because it's a 20-minute procedure and you want to 10 minutes to infuse something and then do it. I must say, I love this drug for VR surgery, but we're not talking about VR here. We're talking about cataract. I just said I have got a lot of interest recently in 1.5 years on dexmedetomidine, particularly for VR surgery. So that, and I think there was one more question somewhere, Ada, and I think we may be approaching time. Right, one of the Dr. Sukamoto had asked question whether TIVA or LMA. I didn't go into the detail of that technique because my remit was to talk on sedation. And I did not mention TIVA, I mentioned TCI, target control infusion sedation. So if you have to give GA, whether you use TIVA or whether you use LMA with gas, doesn't make much difference. But I can tell you one thing, that if you're running the patient under light plane of anesthesia, which I have observed over the year, that's why if I'm using LMA, my personal preference is I paralyze them. Because if you do not have good depth of anesthesia, you will find the eyes rolling out. And the surgeon will tell you, saying, I don't know what you have done, but I can't operate. Because you can operate on a patient awake. Then you can ask the patient, look straight, look down, or whatever. Or if a block is not good enough, still you can do that, ask them. But under general anesthesia, if you've got a light plane of anesthesia, it's not desirable. And you will get the blame unnecessary, saying the patient is not. And to get the deep plane of anesthesia, then you've got a laryngeal mask, you don't have a control much on the LMA, patient away from you, you will get into trouble. So using a small dose of muscle relaxant, probably in my view, it helps me. That's all I can say about that TIVA or LMA, but this was not the remit of my talk today. I think I have answered most of the questions left on the... Yeah, there is one question on droperidol. This is Dr. Chan. Do you have experience in the use of low-dose droperidol? Of course, I can tell you, considering my age, I have used droperidol as a part of the neuro-left sedation, not anesthesia, neuro-left sedation, which used to be. And droperidol, then was causing a lot of problems, but people used to use it. Now, when it has come back into the market with a low dose, it has come as an antiemetic. And I'm not sure, Singapore hasn't got a small dose droperidol in the market. So I have got no experience with the newer one. But what I do know, it came remarketed as antiemetic rather than sedative. What about Australia, Alfred?
What's the drug again?
Droperidol.
Droperidol is available, but we don't routinely use it for sedation, no.
No, it has been remarketed as antiemetic, but I don't think it has taken the market because people are used to on the Cetron or even Aloxi, what is that called? Ganacetron.
Yeah.
So, I'm not sure. Sorry, Dr. Chan, I cannot give you the answer because I have got no experience of using low-dose droperidol.
We don't have it here in Indonesia also. We don't have the droperidol in Indonesia.
Alfred, there is a question for you. I think this is from Dr. Sindriani, Marilata Sindriani, who's saying, what do you think of intraoperative anterior oculi camera bleeding during eye surgery in patients with the hypertension? Did you consider that it could be caused by the peribulbar block? I'm not sure the intraocular hemorrhage is related to peribulbar block. It could accidentally be that you are inside the globe and you have caused that hemorrhage. Yes, suprachoroidal hemorrhage can happen, but there are a lot of other factors than just anesthesia. What do you think, Alfred?
Group perforation, if you do that, certainly can cause it. Suprachoroidal hemorrhage is a complete different story. I don't think that's what the person is asking. Okay. Therefore, I don't think so. It's multifactorial for suprachoroidal hemorrhage from patient factor, surgical factor, and certainly high pressure volume pushing it forward will be. But for just small inside hemorrhage, if you don't have group perforation, I don't know how I can explain for a intraocular bleeding, small one. No.
There is also a greeting from Oya Chok from Turkey. Prof. Prof. Oya say thank you very much, Professor Kumar, and Dr. Alfred. It's always great to listen to your lecture. Hi, Oya. A greeting for you also from Jakarta. Miss you. And there is one question. I think that's I don't know. I don't know. It's asking how about children? How about sedation?
I have answered that on the text. I said the children are usually, that would be the experience. Either the parent don't want it, the children are not ready for local anesthesia and sedation, and the surgeon don't want it. Because children is very difficult to obey commands. They do not understand the problem. They haven't given it the consent. The consent has been given by the parent. So generally, no matter whether it's eye or any other local anesthesia, generally people will say children don't do local sedation unless it is a very small lumps or bumps or something like that, which can quickly get out within 5-10 minutes. Certainly, it's very difficult to justify operation on children. Doing some kind of a investigative work, like measuring pressure or something, people do under sedation, but that's a different. We are talking today about cataract surgery. I don't think any surgeon or anesthetist would like to do local anesthesia with sedation in children. That would be my personal view, but there isn't, there may be more braver people than I am. What about you, Alfred? Are you brave enough?
I have done so. In Australia, all of them are done under general anesthetic, and I did not have any hesitation, and I don't change the practice. I have done multiple overseas trips doing cataract surgery in the remote area, and I have used needle block for children for cataract surgery. Now, I have some success, and I also have some failure, which make me very nervous about doing it. I have done a block on a child that I managed to convince the child to have it. After the block, when the child lie down, put the drape on, he just freaked out and he ripped the drape off, would not have the surgery. Now, it makes you wonder, it's not suitable for every children.
Agree with you, Alfred.
Ada, have you got one more minute?
Oh, yes, there is more question from Sasi.
A question, very interesting question from Dr. Sinatra. I don't know where from. It doesn't say where. But it's interesting question. He's asking, patient for cataract surgery, but sometimes the eyeball of the patient is going up and what should be think? Yes, that's a very interesting question. And I think, I'm not sure whether we can allow, is it possible to allow Sachi Bora to come in the picture. She has done some work on it. And she called it double treble injection. What happens basically, Dr. Sinatra, that if you use a volume of local anesthetic in one corner, either there or medial, the eye tends to rotate a little bit. And this is also known to occur during subtenon block. But that's why some people use sedation, the pressure to get that away. But it is a feature, it can happen. It can happen. The local anesthetic, what you have injected in, either in ferrotemporal or medial or wherever, it makes the eye rotate unless the local anesthetic had diffused. And obviously, to make the local anesthetic diffuse, most people or some people will use hyaluronidase. And that is why one of the things which Dr. Alfred might comment on it, that you try not to repeat the needle injection, because needle injection already in a distorted anatomy by higher volume injection can make life very difficult. Alfred?
I think if you do needle injection and the eye's distorted, doing a second injection, got to be careful. And if I do that, I always make sure the eye pressure is pitted back to normal by ballotment, and you can feel that. And if I do that, I'll only do medial canthal injection. I won't do infratemporal injection again. Or otherwise, I just change the supplement with a subtenon if I were using a needle block.
Sashi Boka had posed another question. I think this subject was, I'm not sure whether Sashi had, I think she had published somewhere, but I've heard her speak. Sashi is raising another question, which is known, but I'm not sure, Sashi, that's a very common problem of sneezing. It is described, but doesn't mean even the 10 milligram constitutes that much sneezing. Sneezing can happen, and so I don't know what the answer is. Sneezing after propofol sedation is known, but incidence nobody knows. It's just a description somewhere, and I think Tom E. talked about it. So Sachi is asking, risk of sneezing with pre-block sedation is real, as is involuntary eye movement. This would increase the risk of inadvertent eye puncture during needle block. Any study looking at it? I'm not aware of, and the problem I find difficult is the surgeon asking anesthetist to sedate the patient before giving the needle block. This is not a problem for subtenon, because even subtenon, you need cooperation of the patient that is looking towards you or looking outward, whatever, and you make the incision. So the sedation is not used, but purely sedation is used for needle block is to reduce the pain of injection. That's one of the reasons for it. And Sashi is posing a question saying, if you have given propofol, a patient sneezes during needle is more dangerous than yes, of course, it could be. But how often you have seen, Sashi, in your clinical practice, sneezing? I have not seen, but of course I have seen some papers in the literature.
How about it, Alfred? Do you see sneezing after sedation when performing block?
There is paper that look at the incidence of sneezing and compare different sedative agent, and they have found that using a short-acting opioid such as fentanyl or alfentanil reduce the incidence by about a third. I personally don't use it because I hate signing the drug book out of it, etc. For oculoplastic surgery, where we inject more extensively, I routinely use it. For cataract surgery per se, I don't.
But don't forget, if you are trying to reduce the problem of one drug, you give another drug and it causes more problem. And I'm pretty sure many of you and most of you have seen, if you use opioid, what the person does, patient, bring the hand near the nose because they get the itching and they want to do that. Yeah, and that's more of a problem because the patient is covered, brings the hand near the, want to do some, stop the sneezing happening or yeah. Okay. That's the problem of the opiate. Even a tiny small amount of fentanyl can do that.
Thank you, Professor. Thank you, Alfred, also for the explanation. I think we already answered all the question, and the discussion is going quite smooth, and I think also we have so many fruitful information in this discussion also. I'm afraid time is up because we already we start earlier, so but it's almost 14:30, so we must stop the discussion and end the session. I like to say thank you to all the speaker, especially Prof. Chandra, Kumar, and Dr. Alfred, who have given us a very nice lecture presentation and discussion, and then also to all the attendees of this session. Thank you very much. I hope that.
Thank you, Eddie, and thank you, Krisa. Thanks.
Yes.
Thank you.
Bye.
Thank you, Prof.
Time to end this session. I give it back to Krisha and Dr. Susilo. Thank you.
Okay, thank you, Dr. Aida, Prof. Chandra, Dr. Alfred. Thank you very much for your time. And I agree, it's a fruitful discussions. I've seen many interesting questions, and both speakers answered it very well. And looking forward for meeting you guys, hopefully next year. Stay safe and stay healthy.
2020.
Oke, untuk teman-teman yang di Indonesia, saya kembali mau mengingatkan bahwa hari ini kita tetap ada giveaway untuk tiga peserta yang beruntung. Jadi terus ikuti Indo Anestesi. Oh, acara kali ini kayaknya salah satu yang ditunggu-tunggu nih, bener nggak sih, Dokter Susilo?
Ya, karena pesertanya begitu banyak, 155, betul nggak?
Peserta apa nih? Peserta apa?
Peserta poster.
Oh, peserta poster. Ya.
Ya.
Pura-pura kaget dulu. Oh,
Selama 18 tahun, peserta posternya begitu banyak, menggembirakan sekali, mengharukan, memberi semangat kepada kita untuk terus maju bersama. Saya kira itu, Chris.
Iya, betul. Apalagi di masa pandemi ini mungkin makin banyak ya, Dok, ya, penelitian, makin banyak kasus-kasus menarik yang bisa diangkat jadi poster, bisa dipresentasikan, bisa dibagikan untuk kita semua. Jadi kita semua juga bisa sama-sama belajar ya, Dok, ya. Mungkin dari Dokter Vida nih sebagai perwakilan Dewan Juri, gimana, Dok, kesan-pesan atau ada yang mau disampaikan nih untuk peserta poster dan seluruh peserta Indo Anestesi?
Ya, ini untuk pertama kalinya ini harus bilang Anda puas, kami lemas.
Ya, cocok. Luar biasa.
Baik, sebelumnya saya perlu menyampaikan terima kasih sebesar-besarnya ya. Saya apresiasi sekali Indo Anesthesia. Coba kita tanya para peserta kenapa bisa begitu membludak, karena yang pertama tentu cara daring seperti ini sangat menguntungkan dari segi finansial. Peserta tidak harus beli tiket, tidak harus cari hotel dan sebagainya. Yang kedua, ini yang saya apresiasi betul bahwa panitia membebaskan registrasi pada semua peserta. Ini buat saya luar biasa. Signifikan banget. Untuk orang yang biasa menyelenggarakan mungkin nggak kerasa, tapi kalau saya pemakai sepatu mereka, para peserta, ini luar biasa keuntungan dan kemudahan, dan disadari maupun tidak, Indo Anesthesia telah membantu kami semua program studi di Indonesia, karena kita tahu zaman sekarang peserta didiknya harus mempublikasikan karya tulisnya. Jadi terima kasih sekali lagi, ini beneran terima kasih, nggak main-main ya. Mungkin tahun depan gini lagi kali, Dokter,
Ya,
virtual aja.
Kita nggak tahu.
Karena sekarang kita bisa melihat bahwa pesertanya itu sangat beragam dari berbagai daerah, tidak seperti dulu-dulu, dan bukan hanya para peserta didik anestesiologis, tapi juga dokter umum dan bahkan ada tenaga kesehatan lain. Jadi ini buat saya luar biasa, ini menyenangkan sekali itu untuk pengalaman.
Bahkan
Baik,
peserta asing tidak.
Kenapa?
Bahkan peserta asing. Kan
Ada
dari
juga ya?
70 negara yang mendaftar.
Oh, ada juga ya.
Totalnya
Tapi bukan untuk poster kan? Maksud saya untuk
Mungkin for the
poster ya, lupa.
ya, mungkin for the future tidak menutup kemungkinan ya, Dok, ya.
iya.
Tidak.
Lagi saya nggak tahu bagaimana sosialisasinya keluar itu untuk lomba poster.
We discuss it after this. Oke.
Oke, back to you, Krisa.
Mungkin buat sekilas sedikit informasi, mungkin Mbak Ratih bisa ditayangkan, tadi udah disebutkan, total kita ada 155 e-poster yang masuk, ada 3 kategori yang kita lombakan di Indo Anesthesia kali ini, ada 98 peserta atau 98 e-poster untuk kategori case reports and case series. Lalu ada 14 poster untuk kategori original research atau penelitian. Lalu ada 43 e-poster ini yang untuk kategori non-anesthesiologist atau mereka yang bukan dari prodi peserta didik residen anestesi ataupun dokter spesialis anestesi gitu. Untuk finalisnya sendiri mungkin saya kasih lihat secara sekilas. Jadi ini adalah finalis. Jadi dari seluruh peserta 155 itu tidak semuanya terpilih untuk mengikuti penjurian yang sudah diadakan itu tanggal 19 Februari kemarin jam 8 pagi. masing-masing kategori itu ada sekitar 10 yang berhasil untuk mempresentasikan e-posternya di depan dewan juri gitu. Mungkin ini yang sudah tidak ditunggu-tunggu, dinanti-nanti jam. Oke, jadi untuk kategori pertama, kategori case report atau case series. Untuk juara ketiga adalah untuk Dr. Willy Yan Kartolo dari Universitas Indonesia dengan judul Post-intubation subglottic stenosis in a child undergoing brief general anesthesia. Selamat untuk Dr. Willy Yan Kartolo. Mudah-mudahan ada ya, dan kita sebentar foto session. Lalu untuk juara kedua. Untuk juara kedua ada Dr. Lalu Ramadhan. Dr. Lalu Ramadhan ini dari Unlam. Selamat. Dengan judul Anesthetic Management for Resection of Pulmonary Arteriovenous Malformation. Dan untuk juara pertama, Dr. Septian Adi Permana, spesialis anestesiologi, ini dari Universitas Indonesia. Wah, ini kasus COVID nih ternyata. A rare case of acute myeloid leukemia with ARDS COVID-19 and bacterial co-infection. Selamat untuk ketiga pemenang. Ini mau foto dulu atau move on? Move on dulu guys. Move on dulu aja lah ya, nanti kita fotonya satu-satu. Oke, selanjutnya kategori selanjutnya. Original research atau kategori penelitian. Untuk juara ketiga, Dr. Budiani Kristina dari Universitas Indonesia dengan judul Comparison of Intubation Time Using Modified McIntosh Laryngoscope versus Migrant Mac Video Laryngoscope in the Adult Population. Selamat Dr. Kristina untuk juara ketiga. Lalu untuk juara kedua, Dr. Ade Susanti, spesialis anestesi dari Universitas Indonesia dengan judul, wah ini berat nih, Urine Albumin Creatinine Ratio, Cumulative Fluid Balance and Sepsis as Capillary Leakage Predictor in Major Abdominal Surgery. Wah, ini penelitiannya keren. Semuanya keren nih kayaknya, semua yang ikut penjurian kemarin penelitiannya keren banget. Next, juara satu untuk kategori Original Research adalah Dr. Mayang Indah Lestari, spesialis anestesiologi dari Unsri, dengan judul penelitian Receptor Interacting Protein Kinase 3 is a Potential Predictor of Sepsis-Related Mortality in the ICU. Selamat untuk ketiga pemenang di kategori Original Research. Lalu selanjutnya dari kategori non-anesthesiologist. Ini kayaknya ada tambahan nih, ada tambahan pemenang. Karena scoringnya sangat-sangat tight waktu penjurian karena semuanya bagus-bagus banget. Jadi untuk juara ketiga, juara ketiga ini oleh Ibu Jui Atia Rahmini dari FIK Universitas Indonesia dengan judul Effect of Back Massage and Sleep Hygiene on Insomnia in Hemodialysis Patients. Selamat untuk Ibu Jui. Dan karena itu tadi sangat-sangat banyak banget yang bagus-bagus, juara ketiganya itu ada 2 untuk kategori ini. Nilainya waktu itu setara tuh. Ini ada Dr. Debbie Claudi dari USU dengan judul Comparison of News to Corp 65 and Q-SOFA in Predicting Severity and Mortality in COVID-19 Patients, a Systematic Review. Jadi juara ketiganya ada 2. Selamat untuk kedua pemenang. Tapi hadiahnya nggak dibagi 2 kan dok? Mudah-mudahan enggak. Enggak, hadiahnya nggak dibagi 2 kok. Selanjutnya, juara kedua untuk kategori non-anesthesiologist adalah Dr. Firca Anakota, semoga saya tidak salah menyebutkan namanya, dari Rumah Sakit Kramat 128 dengan judul penelitian judul presentasi posternya adalah Hematological and Coagulation Parameters in COVID-19 Related Acute Respiratory Distress Syndrome Patients and Observational Study. Wah, ini juga salah satu penelitian yang datang dari COVID-19 nih. Selanjutnya, juara pertama untuk kategori non-anesthesiologist adalah Dr. Dewi Larasati dari Universitas Indonesia dengan judul Pregabalin Premedication and its Effect on Post-Operative Pain, a Systematic Review and Meta-Analysis. Wah, selamat kepada seluruh pemenang lomba e-poster. Tapi kayaknya waktu itu kita udah bilang ya, semuanya actually winner ya dok ya?
Iya ya, all the winner.
Semua peserta yang sudah mengikuti acara ini adalah pemenang. Jadi buat yang belum beruntung jangan berkecil hati. Buat teman-teman semua yang masih mendengarkan acara ini, tetap semangat, tetap ikut e-poster tahun depan. Mudah-mudahan ya dok ya bisa antara online atau offline, nanti akan ada pengumuman lebih lanjut. Semoga semakin banyak penelitian, semakin banyak kasus-kasus menarik yang bisa kita dapatkan dalam 1 tahun ke depan dan bisa dibagikan untuk kita semua. Gitu. Untuk para pemenang udah ready semua kah, Mbak Nis?
Minta dibuka videonya deh.
Boleh yang sudah dinaikkan sebagai mungkin satu kategori kali ya, biar
Semuanya udah. Semuanya.
Semuanya bisa nggak ya di spotlight? Boleh dicoba di spotlight semua.
Ada 10 berarti.
Saya yakin dapat screen-nya.
Bisa nggak?
Bisa nggak?
Ada juara 1 riset, kasihan banjir rumahnya.
Oh.
Kita mesti lap. Mungkin kena hujan dari saya ya.
Imbas dari Jakarta dong.
Oke, foto.
Udah semua nih? Belum kayaknya.
Belum.
Ya. Oke, semuanya para yang sudah masuk silahkan lihat kamera. 3, 2, 1, cium. Oke. Sip, lanjut. Kayaknya belum semua nih.
Yang belum Nis nggak juara soalnya.
Jadi cuma saya yang muncul ya.
Semua udah di
bisa nggak sih, kayaknya nggak dapet deh dok, kayaknya ada
satu layar di tempat saya.
Iya, nggak bergerak.
Satu layar aman.
Coba ya, sorry. Oh bisa, enggak deh.
Nah ini bisa, belum semua sih.
Iya, kayaknya nggak bisa semua deh dok, ada batasannya kayaknya kalau untuk spotlight. Jadi mungkin
satu layar besar, nggak apa-apa.
Yang belum, Mbak Nis boleh bantu di spotlight, yang tadi belum berfoto.
Yang juara 1 boleh traktir tuh.
Waduh.
Ntar malam ya, jam 6 sore.
Malam minggu. Asal jangan bikin klaster baru aja.
Ya, sambil ada beberapa masih. Ya.
Saya udah mesti kabur belum nih?
Belum.
Udah kegatelan mau main band.
Udah ya? Habis ya? Sudah ya?
Udah ya, kayak sisanya 3 ya.
Iya. Oke. Nah, kayak kita lihat kamera lagi semuanya. 1, 2, 3. Kita lagi 1, 2, 3. Oke, baik.
Selamat untuk para pemenang semuanya. Salam buat senior-senior yang di sana tuh yang di Lambung Mangkurat. Salam untuk dokter ini ya, Rapto.
Siap dok.
Ya, Palembang silakan makan cuko banyak-banyak. Yang di Jambi juga double hadiah nih dokter Susilo.
Iya, spesial banget ya.
IPK tertinggi loh.
Aduh.
Yang itu boleh ditodong.
Tapi di Jambi nggak ada apa-apa.
Mati lampu dong. Oke, terima kasih untuk panitia juga.
Baik, terima kasih untuk semuanya. Oh ya, ada kabar gembira juga nih dari Dokter Edi. Terima kasih ada dari Dokter Edi untuk seluruh finalis. yang belum beruntung nanti akan mendapatkan hadiah hiburan dari Indonesia. Jadi nanti semua akan mendapatkan hadiah untuk semua yang sudah mempresentasikan karyanya gitu. Sekali lagi terima kasih dan terima kasih untuk seluruhnya 155 peserta yang masuk. Selamat sekali lagi untuk semua. Again, everyone's a winner. Terima kasih sebesar-besarnya. Apalagi Dr. Susilo ada mau menyampaikan lagi atau Dr. Fida mau menambahkan?
Program will be a special program for us because we can find Professor Janika Melin Olsen. She is a former WFSA president, and Mina Nathan Cherian. She is also famous in the world of anesthesia. Hope you stay with us till 6 o'clock.
Oke, sekali lagi terima kasih untuk pengumuman di poster. Selanjutnya adalah sesi yang seperti biasa dinanti-nantikan. For the next session, we will have another music break. Dr. Susilo and his family and friends. So enjoy, relax, take a cup of coffee, and let's watch.